Once platelet counts start crashing, it's a strong indicator that we're seeing these massive leukocyte, platelet, pathogen aggregates within the microvasculature. And again, that can be the liver. We know it happens in the lung as well, and in some models in the brain.
This is the Sepsis Spectrum, a podcast about antimicrobial resistance, sepsis, and how to expect the unexpected in your practice.
Sepsis Alliance gratefully acknowledges the monetary support provided by Vantive for this podcast series.
My name is Philip Cotton, and I'm a sepsis survivor. 8 years ago, I woke up with severe chills with uncontrollable shaking. By the time I got to the emergency room, the shaking had stopped. Around 3:30 in the morning, I became aware of a nurse in the room. My blood pressure had fallen precipitously, and a code team rushed to my room. I was in excruciating pain as my organs were shutting down. They administered numerous IVs, put tubes down my nose, and inserted a port in my neck. My wife was advised to prepare herself, as I was not expected to survive the night. A CT scan showed an abscess on my liver, which was the proximate cause of my sepsis. I spent 10 days in the hospital, 5 of them in intensive care, where my wife says I was mostly unresponsive and unaware of my surroundings. Prior to the sepsis episode, I was very physically fit, a regular at the gym and a hiker. Because of my good physical condition, I was told I should recover fully, but there was a strong emotional toll to overcome as I realized how close I had come to death.
Hi, everyone, and welcome to the Sepsis Spectrum. I'm Nicole Kupchik, a critical care nurse, clinical nurse specialist, and your guide through the wide, unpredictable world of sepsis, or as we like to call this season, sepsis and multi-organ dysfunction syndrome. On today's episode, we're going to examine the relationship between sepsis and the liver, specifically how they can quickly become unwilling dance partners when an infection turns the body's chief detox organ into both the victim and the accomplice. The clip you heard at the beginning of today's episode was from Philip Cotton, a sepsis survivor whose infection began with a liver abscess that then led to multi-organ failure and a near-death experience. And, listening to his story was just very heart-wrenching for me because we know these patients go through so much. And Philip's story really drives home how fast sepsis can turn a localized infection into an absolute full-body crisis. To help us unpack what's happening at the cellular and systemic level when sepsis occurs, I'm joined by Dr. Craig Jenne, professor of microbiology, immunology, and infectious diseases at the University of Calgary. Dr. Jenne is an internationally recognized researcher whose work uses cutting-edge imaging to reveal how infection and inflammation collide inside the body. I can't wait for you to hear this fascinating discussion. We'll be right back with Dr. Craig Jenne. I am so excited to be here today with Dr. Craig Jenne, who's doing some really amazing and super interesting work up in Calgary, Canada, in Alberta. So welcome to the show, Dr. Jenne.
Hi, Nicole.
So I want to open this up. Can you, because you don't have a typical job, you've got a really interesting job where you do some pretty amazing things. And so can you let the audience know what it is you're up to?
Yeah, sure. We are a basic science lab that's located in a hospital, so lots of clinical friends, lots of translational work. And we use a technique known as intravital microscopy to look right inside living animals, look inside their blood vessels, and watch what their immune cells are doing in models of infection with big focus on sepsis, blood clotting, immunothrombosis, and those other nasty things that happen in our microcirculation.
Which all of those things go together, as we all know clinically, in a patient who's got sepsis. They've got a massive inflammatory response and their coagulation chains are activated. And so, all right, so tell me, how does this go? So you've got an animal that's septic,
Right.
and assuming, are you studying bacterial, viral, fungal, all of the above?
Yeah, sort of all of the above. I mean, we have a large focus on both bacterial and viral sepsis. So bacterial, looking at bacteremia and soft tissue infections. Viral, a little bit more respiratory, so looking at SARS-CoV-2, influenza. And we're really interested in that innate immune response. So what happens when those bugs first encounter our innate immune system? And I think the early stages are very much as we anticipate in the textbook, lots of neutrophils, lots of inflammation. And then after that, things get a little bit weirder with some of these infections when we start activating platelets and we start seeing blood clotting in the microcirculation.
And when you are evaluating these types of things, how quickly are you seeing activation of clotting factors?
So it sort of depends on the model. If we're looking at bacteria, we are seeing really good evidence of thrombin activation within the first hour or two of a bacteremic model. Viral, a little longer. We do have to wait for the virus to get in and start replicating, really, for the body to know it's there. But these acute models of intravenous bacterial administration or intraperitoneal, within an hour, we can clearly see thrombin activation in organs such as the liver.
That's actually pretty fascinating because I think one of the challenges we have clinically is evaluating this cellular activity that's happening in humans. So, do you know, has there been a correlation from the work you're doing into humans? And like, is there a time correlation that you're seeing in humans?
Yeah, the difficult part in humans is, by the time you present at an emergency department or worse, an intensive care unit, we're really guessing at the number of hours you may have been experiencing a given pathogen. There may have been a subacute response for quite a while. What we do know is obviously in severe sepsis, we do see markers of thrombosis. We do see evidence of DIC in human patients. And I think there's been a bit of a mystery as to why we still see general, hemostatic parameters for most patients, even though there's evidence of clotting. What we find by looking in the live animal is we can see most of these reactions are limited to the capillary beds or the microcirculation, and the macrocirculation stays well perfused through things such as the liver or lungs.
Huh. Yeah, because I mean, it's so fascinating. Years ago, because I've been doing this a long time, we had like these probes that were mostly used in research, but they looked at the sublingual circulation in
Mhm.
humans, right? In humans, and what we were seeing is that basically in the capillary bed there was almost like a traffic jam of basically microthrombosis in the
Yeah.
capillaries. Do you know what I'm talking about? Have you
Yeah,
seen this?
absolutely. This is what we're seeing throughout the lungs, throughout the liver, in the kidney. Even in some models, we see it in the brain microcirculation that we're seeing adherent neutrophils. We see platelets piling up behind them. And although we see strong thrombin activation, the really fascinating part from our point of view is that does not always translate to fibrotic clot generation. So we're not always seeing fibrin deposition. Although we can measure fibrinogen and fibrin in the microcirculation, some of these vessels remain patent even though there's strong thrombin activation. And it's really starting to highlight that emerging model there's obviously immunothrombosis, but there's also thromboinflammation where thrombin is driving activation of the innate immune system, activation of endothelial biology, independent of the actual clot formation.
And when you're seeing these open capillary beds, has the model received treatment? Like, have they gotten fluids or antibiotics, or is this just like you're kind of letting nature run its course?
No, we've actually been trying to target the thrombotic side of it as opposed to supportive therapy. So, administration of thrombin inhibitors is highly protective in these models. For example, if we were to give an animal a bacterial infection, Staph aureus or E. coli, and we measure liver damage with a given challenge, if that animal was to receive an anticoagulant at the same time as infection, we can completely inhibit liver damage despite the fact they're experiencing the same number of bacteria, the same bacterial toxins. So it seems to be the actual thrombotic events that are causing the organ damage and not necessarily the pathogen.
And what just so because I'm curious, what are you giving the animals? What drugs are you giving them? It's like
We've
argatroban
used,
or something like
yeah,
that, or
argatroban is our go-to, but, we've done studies of animals on low-dose ASA as well, so this concept of a daily, anti-thrombotic agent and is that protective? But our focus has really been on what drives this thrombosis, and is this different than hemostasis? And one of the principal driving factors behind this are actually the neutrophils and the fact that neutrophils can release neutrophil extracellular traps or nets. Those net structures directly activate thrombin. So if we target the net, so for example, treating a mouse with intravenous DNAs to break down nets, we completely inhibit the thrombin signal, despite the fact we haven't touched the coagulation system.
that's actually pretty fascinating. So now there've been so many studies done in humans, and I know I give presentations on this, and I call it the research graveyard, and I have
Right.
tombstones of everything that's been studied,
Yeah.
and just a lot of things just haven't panned out clinically, and so I wonder, you know, do you know, are there any human studies that are gonna target maybe things like argatroban and things that we have access to?
Yeah, so there have been a number of studies. One of the larger ones was actually led a number of years ago out of Winnipeg here in Canada. They called the HALO study, and that was a high dose, low molecular weight heparin in septic patients. And the interim results of that were showing reasonable protection with an acceptable bleeding risk. So we do still have to be careful, obviously, dosing people with anticoagulants, particularly individuals who may be experiencing DIC, given that it's partly consumptive is problematic. But overall, if done right, we can see improved outcomes in sepsis.
Again, fascinating. Now, years ago, now I'm totally dating myself. We, for I think it's a little over a decade, or actually about a decade and a half, we were using activated protein C.
Yeah.
And then, as we all know, that got pulled off the market. Any thoughts on that?
Yeah, that is a great question. I'd love to dive back into that. I think the early results from that were showing there might have been a clear signal in subsets of patients, but when applied across the board, and I think that's something that these animal models are showing us that if I were to put up pictures of a mouse who has been challenged with a gram positive, a gram negative, or a virus, most people can't tell the difference in the phenotype of the pictures, despite the fact the mechanism driving that may be different. So when we look at a patient, we see that there's coagulation, but the actual mechanism that led to that clotting problem is likely different depending on the agent, and applying the therapy specifically to a given infection model might prove more beneficial than a blanket. You have sepsis, you have a marker of coagulation. Let's hit you with an anticoagulant.
Well, and I think the tough that's the human factor part of all of this is that, like, I think you made a great point earlier, is that so many humans present late. And I mean, let's be honest. You're most people are probably at home sick for days on end before they come to the hospital, and you wonder, like, what we're finding now is so many things that we do are time dependent.
Yeah, absolutely. Time dependent, situation dependent, organ dependent, and I mean that's where we've really been trying to dive into what is driving this concept of immunothrombosis, pathogen independent, time independent. If you have inflammation, what are the downstream effects, and can we intervene? Can we uncouple the two? And that's something the lab has really been tasked with is the concept of trying to uncouple immunothrombosis from hemostasis? Can we preserve the protective mechanisms while toning down or perhaps even eliminating some of these pathological aspects of the same pathways?
Yeah. Well, going back to activated protein C, I have no interest financially or anything,
No.
in activated protein C. But I will tell you, I did see it work clinically in patients.
Yes.
And what I wondered about with some of the follow up studies that were done is, was the drug given to the right patient population? Because the early studies, they calculated Apache scores and they were giving it to much sicker patients.
That's right.
And then
Yes.
follow up studies, the patients weren't as sick and they didn't do as well with the activated protein C.
Yeah, I think that's exactly it. And I mean, I do think there's a lot of area that we can still be working on these concepts of biomarkers or more importantly, broader biofingerprints. I think when we, try to hedge our bets on our two or three favorite markers, they tend to let us down. And we've known about IL-6 now for 20, 30 years. And blocking IL-6 is not protective, although it can still be a biomarker. I think getting a better sense of what are the other 90 blood proteins that are shifting at the same time will give us a much better picture of what's happening in the patient, or perhaps more critically, identify which patients may benefit from drugs such as activated protein C.
Yeah. Well, okay, so let me ask you this question. What are you seeing as maybe perhaps in the literature a promising biomarker for humans?
Oh, that's a great question. We've actually tried to avoid putting our eggs in one basket. I
Yeah.
mean, there was a lot of work,
There's not one.
obviously, on
Yeah.
procalcitonin and other markers. We've taken a step back, and we've actually, some of our clinical partnerships, we've been trying to measure as many biomarkers as possible. So using these multi-arrays of 100 to 300 markers, and coupling that with things such as metabolomics as well, and then we're using that large data set for machine learning. So take the investigator out of it and take my biases out of it, of what I want to see, and instead ask a computer within this field of data, several hundred patients, several hundred biomarkers, are patterns emerging? And we've now been trying to apply that to a couple more focused diseases. And I've got a fantastic collaboration here in Calgary, not quite as severe as ICU sepsis, although some of the patients end up there, is appendicitis. And we've picked up multiple biomarkers, particularly in pediatric cases where the patient is nonverbal and really difficult to assess what's going on. We're starting to pick up biopatterns that we can tell from a blood test whether a person should be prioritized for surgery or whether we can sit and wait on that patient.
Yeah, because there's been so much controversy over that in the last 10 years, especially about appendicitis.
Yeah.
Do these patients need to go to surgery right away or can we wait?
Yeah, especially with the little kids, right? I mean, here we're pretty fortunate in Calgary. We've got a good track record, and still, there are a percentage of patients that we go in and the appendix is perfectly healthy. Likewise, there's a few patients that we think are okay, and we're observing, and we end up with a perforation. So those ones, tragically end up as septic patients in many cases. So this is a great opportunity of trying to understand that inflammatory landscape as a whole, and not just picking our favorite molecule, and say, can we use the body's information as a whole to predict who we need to address right away.
Okay, so I want to talk a little bit about the liver.
Mm,
You've done a lot of work with the liver.
that's right.
You like the liver.
I like the liver. Yes.
Yeah. And it's fascinating. One of the things I know I get on these like little kicks and it's just so many patients who have septic shock. Now I'm talking humans who have septic shock, have shocky liver and they have elevated liver enzymes and we're not like routinely checking them. So let's kind of flip the tables a little bit. Let me ask, like, what are your thoughts? And then what are you seeing in the lab on just the liver's involvement or maybe the liver taking a hit in the setting of sepsis and septic shock?
Yeah. I mean, so liver. We could have a podcast for multiple days on the liver. Uh, the liver is one of those organs that I like to cause a little controversy. I get invited to some hepatology meetings, and I always try to argue that the liver is actually a primary immune organ that just does some metabolism on the side. It
Okay.
is
Is that
truly our barrier, right? Our liver has got more macrophages per unit weight than any other tissue in the body. Those macrophages live directly in the bloodstream. They capture pathogens that come in from our gut. Everything we had for lunch, whatever's getting across that barrier, our liver deals with. And it does a remarkable job of determining, should we react or should we ignore it or immunosuppress to it. It's this wonderful immune environment. And because of that, because it really is that interface of blood and interstitial tissues, all pathogens in the blood interact with the liver, and the liver becomes that front line of the fight between the immune system and the pathogen. We've been quite fortunate that our intravital microscopy can dive deep into the liver. We see Kupffer cells grab pathogens, eat them, recruit neutrophils, platelets adhere. The whole process plays out right in front of our eyes in real time in the liver sinusoids. And the liver's really been that classroom that we've learned a lot about immunothrombosis, and the interaction of platelets, nets, and sepsis.
okay, that is like wild that you're able to see that on a cellular level. So let's hold that thought because I want to come back and
Yeah,
talk about this. Actually, I want to dive in a little deeper because I'm like totally nerding out right now. I'm so excited. So we're gonna take a break,
perfect.
just a super quick break, and when we come back, we are gonna dive a little bit deeper into the liver and talk about these cells that are like doing really cool things. And it's fascinating. I never thought of the liver as being a big immune
Oh,
organ.
yeah, it's just a really meaty spleen.
Okay, all right. Well, let's go on break, and when we come back, let's chat about it. Are you a healthcare professional who wants to stay ahead of the curve? Visit sepsispodcast.org to learn more about how you can receive free CME and nursing CE credits by listening to or watching the Sepsis Spectrum. It's our way of supporting you and together better understanding the ever-evolving world of sepsis care. And now, back to the show. All right, welcome back to the show. So, Dr. Jenne and I are going to dive a little deeper. I'm like loving this topic right now. Okay, so let's go back to the liver because we know the liver is a massive filter. It's a massive metabolizer. It produces proteins and or synthesizes proteins. It plays a huge role in coagulation. Okay, so let's talk about what you've seen clinically in these models, these animal models. So I honestly did not think of the liver as being a big, playing a huge role in our immune response.
Mhm.
So let's just talk a little more. When are you seeing the liver more on overdrive? Is it with bacterial, viral, fungal infections, or it doesn't really seem to matter?
Doesn't seem to matter, like, as soon as something is in the blood, it finds the liver, and the liver, for example, with bacteria, are capturing them within seconds. So first pass through the liver, the Kupffer cells, the resident macrophages are grabbing pathogens. So we could inject, 5 times 10 to the 7, 5 times 10 to the 8 bacteria, and within a matter of a couple minutes, there's none left circulating, and it's all been caught and sequestered by the immune cells in the liver.
And like, I don't mean to sound dumb, but like, what do these Kupffer cells do with the bacteria?
Oh, yeah. I mean, this is the fascinating part is that they are really this decision making infrastructure where they filter the pathogen out of the blood. They can go ahead and then internalize phagocytose and kill it. But it's a Kupffer cell that seems to be the master regulator. Are we going to engage adaptive immunity? Are we going to build a cognate response, or are we going to be tolerant to this? Have we cleared the threat and we can tone down the inflammation? And it seems in the septic models that things rapidly escalate. That once the Kupffer cells have caught and captured bacteria, within that first hour, we start to see neutrophil infiltration into the liver. Adherent neutrophils become these landing pads that we see massive platelet aggregation, different than a clot, but these loose aggregates of platelets. And those then communicate with the neutrophil, and platelets binding to the neutrophil trigger other functions such as net release. And it's this really interwoven network of Kupffer cells, neutrophils, and platelets that drive inflammation in the liver.
Wow. Now, one of the things we see clinically in humans is we see low platelet counts,
Hmm.
especially in our sicker septic patients. And we
Hmm.
often look at that as basically a marker of severity or even of like organ dysfunction when platelet counts drop. And we know that there's phagocytosis of platelets, but how do we make that tie? Like, why are we seeing such low platelet counts in really sick patients?
Yeah, there will be some platelet phagocytosis, some platelet death, but much of it, at least within our animal models, is sequestration. So we could measure animals becoming thrombocytopenic within 3 to 4 hours of an IV bacteremic model. And if we look in the lungs and we look in the liver, they are packed full of adherent platelets. So these
Oh, huh.
circulating cells have actually started participating in that immune response. And in the liver, they could do things such as forming aggregates and shells around the bacteria to try and wall them off. They communicate with the neutrophils. They drive net formation, and directly contribute to pathogen clearance.
Wow. I mean, it's just so fascinating. So is there a tie between low platelet count? I know you're looking at animal models, but I'm trying to kind of be the conduit back to humans. I- Is it true, or would this statement be true that when patients drop their platelet counts in septic shock, that is a marker of the severity of their illness?
Yeah, in our animal models, it absolutely is. Once platelet counts start crashing, it's a strong indicator that we're seeing these massive leukocyte, platelet, pathogen aggregates within the microvasculature. And again, that can be the liver. We know what happens in the lung as well, and in some models in the brain. But it is more than just this passive platelet aggregation or thrombotic or pre-thrombotic kind of events, depending on the pathogen. So we've published data showing that some bacterial models, if the platelets are absent when those Kupffer cells capture them, the mice will die, and the platelets are critical at actually forming a bit of a protective shell and walling off the pathogens. In the absence, we see endothelial cell death, we see vascular leakage, we see a rise of hematocrit, suggesting again fluid loss through the vasculature, and the mice don't do well.
Oh, fascinating. Okay. This is like all mind blowing to me because, again, clinically, I think I've been doing this for 3 decades and we've been searching for the holy grail in sepsis. And I think, it's not one thing.
No,
It's everything working
no,
in
I mean, like
concert.
one of the dilemmas we try and ask in the lab is that question about once a animal becomes thrombocytopenic, is there value in bringing platelet count back up? And we know platelets are protective. We obviously have to maintain hemostasis, but if the platelets are also driving inflammation, if the platelets are driving immunothrombosis, do we essentially add more fuel to the fire by bringing platelet counts back up? And I think the question really is going to depend on that hemostatic risk. If the individual's not bleeding, perhaps they tolerate lower platelets for a short term.
Yeah.
But if they're bleeding, we obviously have to deal with the acute problem first.
Yeah. Well, and I think the other thing that is so extremely complex is you've got this liver that's acting as an immune machine. And then on top of it, that liver is often hypoperfused.
Yeah, so our imaging and data has been very clear that these platelet neutrophil net aggregates drive local thrombosis. We do see clots. We do see fibrin containing clots within the microvasculature, and we can measure areas of the liver that are no longer perfused. So these are areas where if we put a contrast agent in, we do not see perfusion through these islands in the liver, and can actually track hepatocyte death in those areas, and those islands correspond directly to rises, for example, in ALT. If we intervene, if we block that clotting, so whether it be argatroban or we added DNAs that actually completely short circuits the immunothrombosis, the liver doesn't seem to demonstrate that damage, nor do the kidneys. And despite the animal is still fighting the same pathogen load, still has the same neutrophil recruitment, eliminating those ischemic patches seems to be highly protective in preventing liver damage, liver death.
Okay, I'm just sitting here just totally dumbfounded. This is so fascinating. Okay, so making that clinical connection, do you foresee studies that are going to maybe in a randomized control trial in the right patient population evaluate drugs like argatroban?
Yeah, I mean, we'd like to see that. We are still learning, right?
Yeah.
And we are, the problem is for every good idea, there's 8 or 9 critical exceptions to the rule. And we've been dealing with some respiratory viruses and molecules that interrupt coagulation and severe viral infection, for example, are highly protective. But that exact same virus, given it a lower inoculum, a lower challenge, so a mild infection, those molecules that interfere with the coagulation cascade actually convert our mild infection to a lethal infection with with mild viruses. So yeah,
Oh, yeah. Yeah.
it's one of those ones that we joke around, or I joke around that it's a great tool eventually if we can get these into clinic, because if my kids complain that they're too sick to go to school today, I can tell them I've got a drug that'll cure you if you're really sick, but
Yeah.
if you're lying, look out.
You're gonna get in a lot of trouble.
That's right.
Oh, man. It's so fascinating. Okay, so let me ask you this. What are so you're still working in the lab.
Uh-huh.
What are you excited about coming down the pike? Let's say like in the
Yeah.
next decade. Because let's be honest, research takes a while, right?
We've seen some really wonderful advances in areas such as nanomedicine, where we could take some conventional, therapies, argatroban, for example, and we can formulate that in a context where it is targetable. So we could IV administer a broad acting drug, a thrombin inhibitor, but the way it's packaged, it only gets released at specific sites in the body. So we might be able to functionally uncouple again hemostasis, where we're getting sort of extrinsic thrombin activation from immunothrombosis, where there would be neutrophils and nets and a different context. So we're quite excited about the concept of being able to develop context-dependent drugs that only become activated within a specific environment and not globally. We're also quite excited about we've often approached things such as immunothrombosis as just these are procoagulant events. So thrombin activation, platelet participation. We tend to ignore the other side, the actual fibrinolysis, and we're slowly learning a lot more about how things such as plasmin are regulated during inflammation and how structures such as neutrophil traps might again modulate that clinically what we're seeing may not be just a prothrombotic event. It may actually be a combination of we generate a little bit of thrombin and then we don't clear the small clots or small thrombi that are made, and things snowball from there. So looking at both that fibrinolytic side, but also critically these context dependent drugs, I think are very exciting and offer a great deal of potential in the future.
Yeah, I'm excited to just understand like what you find in the future. I know all this is going to take time and to really drill down, but I just feel like like I said, I've been doing this 3 decades, and I feel like we've made some headway in treatment of patients who have sepsis. But I feel like there's just so much more to learn,
Yeah.
and I think that just speaks to the high complexity of the disease.
Yeah, I mean, I know it's so simple to say and so off the cuff, but this concept of precision or personalized medicine really has to be embraced in that, we've known, as you said, for decades now, not all septic patients are the same. Yet it seems to be a lot of therapies are simply based on symptom support or end product support and not diving into the unique mechanisms that each patient may be experiencing. In the past, that concept of personalized medicine may have very, very much eluded us because of cost and time and but today, I mean, we can generate more data than we could possibly analyze in a matter of minutes to hours. And being able to embrace these large data sets, machine learning, and the idea of looking at the picture as a whole and not one molecule or one cell, I think is going to open an awful lot of doors for tailoring even therapies we have today, but tailoring it to the right patient at the right time for better outcomes.
Yeah. All right. Well, I'm excited to see what the future holds. Well, I just want to thank you for joining me today. I'm really excited that there are people like you in this world who like to do this type of research because it is so important. And we've got to start somewhere. And you're definitely at the foundation of just building the science
Uh,
that we need to advance
oh, it's
what
an
we're doing
absolute pleasure
clinically.
to chat with you today. I mean, yeah, this is it's fun that after 20 plus years, it's still exciting every day.
That's amazing. That is awesome. So, all right. Well, just thanks again, Dr. Jenny, for being here today. I had so much fun talking with Dr. Jenny about the work that he's doing in the lab and specifically looking at the liver and the immune response that the liver plays a role, which I'll be honest, I had no idea that the liver did so much when we're infected. I had no idea. And I think it was just fascinating to talk through like exactly what the liver is doing in the Kupffer cells and platelets basically attacking the bacteria that is invading the body. So just fascinating work. And, the question we always ask is, how is this going to drive future research that would help patients at the bedside? So super exciting stuff. Thanks for joining me on today's episode of the Sepsis Spectrum. If you have a story you want me to read on the air, visit www.human-content.com/sepsis. And if you're enjoying the Sepsis Spectrum, we want to hear about it. Please leave a review wherever you're enjoying this podcast. It helps a ton. You can also reach me and our awesome team at info@sepsis.org or visit sepsispodcast.org to share any stories of your own, questions, concerns, or episode ideas. To learn more about Sepsis Alliance, visit sepsis.org. The Sepsis Spectrum is brought to you by Sepsis Alliance. I'm your host, Nicole Kupchik. Our executive producers are Allison Strickland, Hannah Sass, Claudia Orth, and Alex Colvin. Our producers are Aaron Corney, Rob Goldman, Shanti Brook, and me, Nicole Kupchik. Our post-production producer is Sundas Hasoon Noli. Our editor and engineer is Jason Portizo, and our music is by Omer Benzvi. To learn about Sepsis Alliance's podcast, legal disclaimer, and compliance policies, you can visit sepsispodcast.org/disclaimers. The Sepsis Spectrum is a Human Content and Sepsis Alliance production. Thanks for watching. I hope you're enjoying the Sepsis Spectrum. Leave a comment below and let me know. If you want to binge some more episodes, just click that playlist right over there. And if you're feeling super generous today, give this video a like, subscribe if you haven't, hit the bell, all the things. And of course, you can also listen on the go wherever you get your podcasts. Bye.